My name is Mark Carroll, and I'm with the Focused Ultrasound Foundation, and will be the moderator for today's panel on real-world examples of focused ultrasound site success. Building a successful focused ultrasound practice is a complex process that goes well beyond knowing how to use the technology. Given its relative newness, achieving success with focused ultrasound requires a knowledge of the regulatory and reimbursement limitations that determine on whom, when, and where the technology can be used. It also requires the ability to navigate the complex political climate within a hospital or practice that arises when a new technology threatens to replace a more established way of doing things or changes specific patterns of care. Today, we have a distinguished group of successful focused ultrasound surgeons who will share with you some of the ways they have navigated this complex landscape on their way to finding a role for focused ultrasound in their daily practice of medicine. Stephen Cianti is in private practice in Sarasota, Florida, and is the director and founder of the Cianti Prostate Center. He has specialized in prostate cancer ablative surgery over the past 15 years and has extensive experience with cryosurgery, with MRI-guided fusion prostate biopsy, with focused ultrasound ablation of prostate cancer, and more recently with the TULSA-PRO technology. Matthias Matsko is chief physician of the Department of Clinical and Interventional Radiology, Helios Amper Clinic in Dachau, Germany. And he's also the head of the Focused Ultrasound Center for Uterine Fibroids. Since 2013, he has held an honorary appointment as a member of the Medical Quality Assurance Commission of the Bavarian Medical Association. Roberto Blanco Sequeiros is chairman and professor of radiology at the Turku University Hospital in Finland, where he also is research group leader for image-guided therapy projects. He actively participates in planning and implementation of MRI clinical research, and his main interest is related to establishing a comprehensive clinical research center for HIFU. Seppersani is associate professor and director of stereotactic and functional neurosurgery at Rush University Medical Center in Chicago. His area of focus is deep brain stimulation for the treatment of movement disorders, including Parkinson's disease, essential tremor, dystonia, and psychiatric disorders, as well as epilepsy surgery. And he includes the use of MR-guided focused ultrasound ablation in his clinical practice.
So hi folks, my name is Roberto Blanco Sequeiros, and I'm the chair of the Turku University Hospital Radiology. And on this talk, we're going to briefly go through the setup of center of HIFU in Finland. And for us, this has to work very well. And the talk includes some basic principles for the setup of center. So basically, what are the requisites for the service? Of course, the primary one is the clinical need and mindset for HIFU. And this has to be born on the clinical side. So basically, the clinicians need to be interested. They need to be ready for this. You have to have a premeditated clinical and research applications, for instance, like fibroid, MSK, musculoskeletal, or prostate. And regarding IRBs, you need to recruit a clinical PhD student as well as part of a crew, because otherwise it's going to be very difficult to process the data which comes from the clinician. So these guys are very important. So you have to have the clinical PhD students with you if you are about to do research. And if you're going to do the purchase and the statistics, those have to be projected on the number of treatments you're going to make. So basically, good planning is very important. Well, in Turku, the funding of the HIFU device was mediated through the regular investment protocols and budget, with the conjunction of purchasing a scanner, MRI scanner. So we basically got it with the regular investment budget, which was very fortunate for us. And we placed a tender for MRI HIFU system and optional prostate application for the year 2016, and the installation was performed on 2017 for the prostate. So what makes up the setup easier? Obviously, if you have exposure on MRI-guided interventions, that makes things much easier. In Turku, we had a 15-year history with performing MRI-guided interventions here in radiology, and so that was a big help for us. So the staff and the techs were ready and excited to expand and to adapt to IGD regarding HIFU. Also, the vendor commitment is very important. So we were unfortunate in that sense that at the time of the installation, the HIFU equipment was manufactured actually in Finland, and the Philips setup was the factory setup was very close to us. It's only about 100 miles from Turku, so we had a very good communication with the vendor, and that's also very fortunate. So how to start? It's better to start easy, small steps, not rush things. One thing which is important to note that you're going to lose some diagnostic scanner time, so you have to be prepared for that, and you have to plan your scheduling accordingly. The PI must be involved and present through the process. So if you're a PI, you have to be ready to allocate your time to this. And also the communication is very important. That's part of the leadership to make things a success. And here is that typical setup for us. I mean, you have a urologist on board, you have an anesthesiologist, you have the techs, and of course you do have the radiologist there as well. So basically, I'm not pointing out any particular specialty here. I mean, this setup could be run by urologist or radiologist or any clinician or radiology staff. It's the most important thing is that you are working as a team. So doing things together, that's the most important thing. That's that. That's the setup thing.
Hi, my name is Seppersani. I'm an associate professor of neurosurgery at Rush, and I'll be talking to you about a clinical program with MR-guided focus ultrasound with a strong emphasis on how we got our relatively new program off the ground and how far we've come so far, and what were some of the main elements that led to us having a relatively quick ramp up in terms of volumes and treatments. My disclosures are, these are the industry support that I get for my fellowship training Okay, so just to give you a brief background, our program here at Rush is essentially an academic medical center, but it's a private hospital which can mimic a community hospital with an academic affiliation. And much of the approach that we've taken is in very much parallel with how a community center would approach acquiring this new technology and setting up a program from ground zero. Just to also emphasize our market, for sake of comparison, we're in Chicago, which is a large metropolitan, high density population with multiple academic centers. However, we are fortunate that we're the first to acquire the focused ultrasound treatment technology in not only our local market, but also in the surrounding states, which allows us to be the first in and have the ability to market this in that capacity. So one of the things that we did after the decision was made to acquire the technology, and while it was being acquired and implemented and installed, at the same time, we as a team began to assemble the team and find out who will be our referral sources. We identified them very early on and began conversations. In our own community, the local hospitals, we quickly came up with a list of all the movement disorder neurologists who did treatments for essential tremor and ranked them by how busy they were and began to inform them about this upcoming technology, its indication, on what it was about. We also learned that there is a large number of primary care physicians in the greater Chicagoland area who treat patients with movement disorders, and they're the primary care providers. So we also met with them and addressed them. It was in addition to meeting with our own movement disorder section. We were lucky enough to have a very large neurology program with a very large movement disorder section. And so we gave ground rounds, met with them individually, made sure they fully understand the technology, indications, and who are appropriate patients. In this particular type of technology, it's important to emphasize that there is no surgery by way of an incision, there's no anesthesia, so that barrier is clearly down when they speak with their patients for referrals. In addition, Insightec, the company who owns the technology and provides support, was absolutely instrumental because they have a very large database of patients who are interested, and they also have significant information on local markets and who are the big providers, referring sources, and they're very well imprinted in social media. And then since then, once we got this individuals identified, we got referral sources identified, we gave many presentations. We went grassroots, we gave presentations, and nowadays with the pandemic, much of this can be done virtually to support groups, to surrounding institutions, whether it's community hospitals or academic centers, foundations. We had website symposia, and we basically have now incorporated a rotation, and once every few months we do this so that the information remains fresh, and we augment it by keep providing outcome data to our referral sources. We have also made sure there is a very distinct and easily identifiable website, social media presence, which is key because these patients are very savvy. They're very present online, not just communicating with each other, but also they look for information, and most of the patients actually reach out directly. So in that regard, it was very important for us to identify what components are needed for a successful program. Obviously, a treater in our institution, a neurosurgeon. We also work with our neurologists very closely, who are instrumental in evaluating the patient's candidacy. But I cannot emphasize the importance of having a dedicated program coordinator. This is an intake person who is responsible for capturing all inquiries by patients or referring physicians and making sure they're quickly evaluated and scheduled so that we don't lose those patients and continue the education and evaluation of their candidacy. Then the remaining portions of the team, we identified an MRI technologist who went through training and is a consistent person who runs this because this is very image driven. We need to have a consistent team that goes through the learning curve and helps and becomes part of the workflow. We also have a dedicated advanced practice provider and an RN who participate in the procedure time, and they're a consistent staff who develop a relationship with the patient, adds to the personalization of the program for the patient. And as discussed, a very robust and live and continuous marketing approach. In closing, the same old rules were also applied to launching this new program for us that have resulted in relatively good success so far in a short period of time. But I cannot emphasize again the availability, which is one of the A's of success in providing care, has been much helped by us having a coordinator who is able to receive every inquiry within 24 hours, respond, establish a relationship with potential patients, and get them through the process of a workup, insurance approvals, answering questions, especially at our center, which is a large center, and something as little as how do they get around. So that has been huge. Being able to establish personal relationship with referral sources has also been very important for us. And lastly, we started out slow. We started out with ideal cases to ensure good outcomes that establish the trust of the community and the patients. And since then, we're ramped up, and we're now more comfortable taking on more challenging cases. And that has been also something that has been favorable for us. Hope this information is very helpful, and thank you.
Well, hi there, Dr. Steve Cianti here from Sarasota, Florida. And today I'd like to share with you my experience in building a focused ultrasound practice. This really goes back for me a journey of about 20 years, starting with ablation treatments for prostate cancer, initially in cryotherapy, and then moving very quickly to focused ultrasound ablation with the Sonoblade device, even years before we were able to achieve FDA approval. Today, my practice really is built completely around imaging-based diagnostics and really built around offering patients alternatives to standard surgery and radiation therapy approaches. And so the typical patients that we see today very much are looking for an alternative treatment. But I think the most fundamental thing of importance as you build a practice like this is to have a belief that ablation and focused ultrasound particularly can provide effective approaches to prostate cancer treatment and provide the patient with a good balance between treatment and really maintaining quality of life. If that belief isn't there, if that paradigm change hasn't been adopted in your practice, it'll be very hard to build a program like this. The fundamentals, though, really do require some skill sets that are very important, probably the most important of which really is imaging. You've heard, I think, throughout this conference from our MRI colleagues, our radiology colleagues, that importance. The most important thing that I had to do was to develop a strong relationship with a radiologist skilled in prostate MRI. And that was more of a partnership in which we worked together to review our cases and really begin to understand how lesions are being called and understand the language we both could share. But as we began to develop that program, especially since FDA approval, we had to navigate the reimbursement landscapes. This is critically important because at least with HIFU and with the Sonoblate device in particular, we had to really spend a lot of time working with our hospital in partnership to work with the reimbursement, the facility reimbursement code that was introduced, the C code as it's called. And that took a lot of work with the hospital billing staff. As a consequence, we've had hundreds of patients that have been able to have been reimbursed through the C code, which cut down the patient's out-of-pocket costs in a very, very significant way. So that barrier to treatment in our program really was diminished. Since 2015, I've personally been involved with treating around 750 patients with HIFU. Now, as TULSA's come along, that's another tool. We're going along the same pathway, but another tool to deliver an ultrasound to the prostate, depending upon tumor location and appropriateness. One treatment, and we've talked about this, will have places and advantages compared to some of the other platforms. Moving forward, though, especially come January, we now have a CPT code. That's very exciting because now there's more of an ability to help a patient achieve reimbursement on the Medicare side as well as on the private side. And certainly these discussions have been already undertaken with our local hospital to understand the navigation of the new CPT code and what that means and how they'll deal with the patients in that regard, as well as how my practice will deal with the patients. So I think it's really starting with having a core belief that focused ultrasound ablation affords the patient a better balance between treatment and quality of life. It's developing the skill sets to deliver the treatment, mastering the platform, mastering the software. It's getting comfortable with image-guided ablation. It's having a good partnership with your radiology colleagues. And again, it's having a strong partner with the hospital who understands the navigation of this very complex reimbursement landscape. But above all else, it's a passion to bring this technology to patients that I think has allowed us to build a very large and I think a very successful focused ultrasound practice. So with that, I'll look forward to taking questions when we come to our panel discussion.
Good evening, my name is Matsko. I want to tell you a little bit about the development of our focused ultrasound center located in the Munich area near the Munich surrounding in a 450 bed hospital. Actually, we started with our focused ultrasound center in the year 2008. As the third center in Germany at all. So we are the only center that survived until now. So what did we do to win this battle? At first, beside all the investment stories and so on, I think the most important thing is to really address to the patient, to know what the patient needs, and also to offer other treatment possibilities for the patients beside focused ultrasound, like uterine artery embolization or the whole operational and surgery spectrum, to be in a position to tell the patient what is best for him. So bringing good clinical results in your treatments will lead to persisting in the turf battles with other doctors like gynecologists, and you can convince, of course, referring partners. Second thing is, it's very important to provide a constant and high quality therapy result in the daily routine. So this is only possible when you do a good selection of the patient. So our recipe was starting small and growing big. Initially, we invested only in a focused ultrasound unit, and we docked it to our existing diagnostic magnet. We hired 0.5 full-time equivalent patient manager, and we did some low-budget marketing activities like an internet presence with our own webpage and flyers, and of course, we did presentations for referring doctors and gynecologists. But soon we noticed that is not enough. We had to address our possibilities directly to the patient, and that's why we established kind of patient service to come in to get their MRI imaging and then have a talk with the doctor about the treatment possibilities, so that you are in a direct contact with the patient, and you can select the right patient for this therapy. We have around a 70 to 75% denial rate. That means only a few patients that show up in the center can be finally treated with focused ultrasound. We built up, meanwhile, a very good collaboration with our gynecology partners in the hospital, because actually we are one of the most big referrals to them. Meanwhile, all the patients that are joining our center are coming not only from the local surroundings, but all over Germany, and also from other European countries, and even from other parts of the world. So patient service, I think, is the most, the second success factor. Hospital-based location is a benefit for the patient. You have the availability to take care of them before and after the treatment. If they are not feeling well, they can stay overnight, and you don't have to send them home. 90% of our patients are contacting us over the internet. So I think the social media as a platform is a very important tool to gain income as well, like Google Ads, Facebook, and so on. So you have to, I think, use this as a tool as well. So when you have treatment success, this of course spurs the reimbursement and pulls the interest of not only the media, but also the insurance companies. And finally, we succeeded to have some of them to get reimbursement. And that's the only center in Germany that has this advantage at the moment. So that's how we did it. And I'm looking forward to the panel discussion with you.
Thank you very much, panelists, for those presentations. Interestingly, you each covered a different area, which is great, leads to some questions, excuse me, to share with each of you. So to start with Dr. Matsko, Dr. Sani shared with us the importance of collaborative practice this harkens back to the early days of stereotactic radiosurgery, where we had neurosurgeons, neurologists, imaging doctors, medical oncologists, all working together for the benefit of the patient. How does this factor into your practice in the gynecological arena?
Well, actually, we have, you can call it advantage or disadvantage. You don't need so many other disciplines to do a treatment for uterine fibroids. This does not mean that you don't have to collaborate with clinical partners. So, of course, it is important to have the gynecology of your hospital on board, to join them and to work together. Otherwise, in the long-term run, you will not be successful.
Great. Dr. Sani, Dr. Matsko mentioned the importance of referrals and referral patterns in a practice. In a university setting such as yours, how important are referrals from the outside community as opposed to from within the university itself?
Well, for us, the importance of outside referrals are as high as our departmental referrals. You know, obviously, we're lucky to have a large movement disorder program. It just so happen to be in a university setting, which is fine. However, for a large volume treatment program such as this, for the longevity of the program to persist, you need to have a very reliable and robust outside referral source in order to be able to satisfy the needs of the program in the long term. So for us, currently, we are at approximately 50-50, whereas half of our referrals come from outside, and the other half, whereby they are indirectly from outside, they are first vetted internally by the movement disorder department before being referred to us. So they're both vital.
Very good. Dr. Cianti, we have a question from the audience. Have you seen or do you expect to see that patients, particularly younger patients with prostate cancer, are less willing to accept active surveillance and would instead prefer to get focused ultrasound treatment for their established but presumably low-grade disease?
That's a great question, Mark. Yes, I think a lot of men are uncomfortable with surveillance, no matter how much I think it may be very appropriate and certainly within guidelines for that patient. The main reason that they may choose surveillance is because they really don't want to accept the burden of side effects that go along with their traditional treatments. So we can offer that patient more of a personalized approach, particularly where we can treat a tumor focally and preserve important structures and leave them fully functional. That becomes a proposition they're much more comfortable with, as opposed to radical therapy or simply surveying a cancer.
Sure. Do either of you, Dr. Matsko or Dr. Sani, see a similar corollary within gynecology or within intracranial applications? So in the prostate cancer space, we have active surveillance and we have invasive surgical procedure. And some argue, perhaps evolvingly inappropriately, that focused ultrasound is sort of a halfway step between the two. The benefits of active surveillance, meaning limited side effect profile, plus the benefits of invasive surgery, meaning disease control. Do you see something similar, a similar dynamic in the gynecological or intracranial spaces? Dr. Matsko, why don't you go first?
Well, I think it's not only the advantage that it's a kind of very minimal invasive treatment, or call it non-invasive, whatever you like, but also the anatomy sparing part of the of focused ultrasound is, at least for the patients, the most important reason to in a benign disease like uterine fibroids to go for focused ultrasound. It's a little bit different if you treat prostate cancer, of course. This is a potentially, even it's a low grade, it's a potentially life-threatening disease. And So I think the most important reason for patients to go for focused ultrasound with prostate cancer is that they get their local tumor in a kind of therapy, and not only sit there and wait and get nervous over the time.
Very good. Dr. Sani, in the intracranial space?
So for us, in terms of treatment of movement disorders, specifically tremors, it's more of a question of quality of life. And I tend to agree with Dr. Matsko's rationale here. As opposed to a cancer treatment, for us, we've noted that focused ultrasound creates a treatment option for patients who have severely affected quality of life because of tremors. And before this, the only options they had was to either live with it with an exceedingly low quality of life or undergo an invasive surgery, which is deep brain stimulation, with adequate results. However, the barrier was very high because it involves surgery and implantation of a device with maintenance. And what we've learned is there is a great space, there's a large subpopulation of patients with severe disease who would never opt for invasive treatment, no matter how severe the disease got. And therefore, this does offer significant improvement in that quality of life for this group of patients who, for whatever reason, would have never come forward. So I hope that helps answer that question.
Yeah, I would love to be able to spend more time on this topic, because quality of life seems to be a common theme running through each of the three different organ systems here. Unfortunately, as much as we're clinicians, we're talking about successful clinical practice. So Dr. Cianti mentioned that one of the critical factors in his ability to develop a successful urology practice was a strong relationship with his imaging colleagues. How does that apply in the intracranial and gynecological space? Dr. Sani, why don't you go first this time?
So at the outset of our program implementation, having quote-unquote buy-in from our radiology colleagues was, I don't know how to describe it, it was essential. Without it, the program would have never launched, just because of the virtue of the fact that this is an MRI-mediated treatment modality, and getting the right acquisitions, maintenance, so that has been huge for us. And that collaboration continues to evolve because it's an evolving technology. So for us, it was paramount. Without it, we would have never been able to launch. And that relationship continues to pay benefit to both sides, radiology and neurosurgery.
Dr. Matsko?
Yeah, for me as a radiologist, of course, especially at the beginning, it was mandatory to get input of the gynecology department of our hospital. So I was very lucky that I got a very intense input, meaning we looked at patients together. So from our radiological standpoint, and we learned a lot about the possibilities of gynecology, what to do in treating fibroids. And at the end, after 3 years, I got such a gynecological extra knowledge to my radiology knowledge that meanwhile we are going on our own. So this strong and intense contact is not necessary anymore, and it's of course time sparing when
right.
you don't need to check every patient with your gynecological counterpart.
Right. For all three panelists, a question from the audience. How do competitor treatments offered in your centers for the respective indications influence the uptake of focused ultrasound in the community practice? And I'll start with you, Dr. Cianti.
Well, certainly there's established competitive treatments, and the majority of patients have quote unquote standard therapies today. It's more still the unusual patient who has focused ultrasound. And so I don't think we're really at this point, we certainly don't pose any practice threat to any of our colleagues that are experts at prostatectomy or offering radiation oncology. This is a patient-driven treatment. These are treatments that patients seek out and really will hope that they're acceptable candidates for treatment. And perhaps, for example, in my center, literally 80% of the patients that I treat today come from outside of the state of Florida. So these are patients that are seeking an alternative. And I think what we do very much it offers an option, an important option for our patients.
Dr. Matsko?
Yeah, same for us. It's around 80 to 90% are not located in our surrounding. The patients come from all over Germany, and this leads, of course, to a maximum plus of patients in the gynecology department of our hospital and our interventional radiology unit performing the uterine fibroid embolizations as well. So for us, it's a plus to have focused ultrasound in our spectrum. And of course, the patients, as Dr. Cianti said, the patients are looking for an alternative, and they find it in focused ultrasound. And it's a very special group of patients, I think, that select this treatment.
Dr. Sani?
Yeah, I concur. For us, the other competing treatment modalities for intracranial movement disorder tremor treatment, these are complementary. There are patients who have come to us specifically seeking MR-guided focused ultrasound, but have been found to be better candidates for deep brain stimulation. So we have noted that there has been a net increase in our deep brain stimulation patient volumes. However, a large number of patients who come already know about the complementary and competing treatments, and they've chosen against it. At least in our space, the movement disorder patients are very well educated. By the time they come to see us, the great majority of them, being self-referral, seeking their own primary or referring physician's advice and coming to see us, they already know about the other treatments. They have done the Google search, and many of them have already contacted information sources. And so we think that this provides an alternative for patients who seek that specific alternative. So they're complementary.
For Dr. Cianti, he mentioned 80% of his patients come from outside his immediate catchment area. And for Dr. Matsko, it's 80 to 90%. What about for you, Dr. Sani?
Right now, about 50% of our patients come from outside. And that merely speaks to probably a bit of a different structure that I have here at our institution compared to Drs. Matsko and Cianti, being in a university setting with a large established movement disorder program that feeds patients to us. I suspect that's the only reason why the percentages are slightly different.
In the early days of radiosurgery and stereotactic radiosurgery, one of the arguments for bringing the technology into a hospital was that there was a carry-on effect to the institution as a whole. That is, the facility benefited above and beyond just the cases brought in for that specific procedure. There were patients coming in who didn't need that procedure, who ended up staying in the facility, in the hospital, to get their care. Are you seeing this as well in each of your disciplines, Dr. Cianti?
Absolutely. We partnered with a small hospital that like to do more niche procedures, but really they're very proud to be the first in the area to offer new technology. And what's happened is that a lot of their associated programs grew. So their MRI program has gotten a lot busier. Their MRI has grown from underutilization to being maximally utilized. They've now incorporated a fusion biopsy into their offerings. And so because we raised the awareness of this novel approach, all the associated procedures that feed into this have really gotten a lot busier. So I think they're very happy that of our relationship.
Dr. Matsko? Yeah, same for us. We established an extra MRI only for focused ultrasound, and this is used for all the therapies. Of course, we do a treatment every day, and we are fully booked until I think next February. So, and we combine this with a lot of MRI pre-examinations to see if the patients are suited for therapy. So it's a big plus for our hospital.
Dr. Sani?
I concur, and that's actually a great question because it's difficult to measure the downstream washout effect of new technology just brought into an institution. But at least for our case, in the movement disorder tremor treatment modality, this tends to be a very quote unquote happy treatment where patient outcomes are dramatic and they're very happy. And we also tend to be the first exposure of these patients to our inpatient facilities. So providing a good service with a great outcome has allowed us significant exposure in the community in the surrounding states by way of these patients carrying the word about such a happy treatment. So it's a plus, plus, plus.
Very, very good. A companion question, if you will. We'll start with you, Dr. Sani. How important or how difficult has it been to get your facility, be it academic center, community hospital, et cetera, on board with what you're doing, since it does rattle the status quo, and it does, in some instances, for instance, in Dr. Matsko's case, upset the normal referral patterns?
So for us, I guess the word difficult is not what I would say. It has been labor intensive, and you hit the nail by way of there needs to be buy-in twofold. One, administratively, and that you just have to put together a business plan that makes sense, and it's prudent to do so anyway. If you're bringing a technology that costs money for the institution, it is prudent to have one going forward, and it can be done. The second thing is if you are bringing a technology that's going to compete with some existing technology or treatments that are being offered by competitors, the approach that we used was collaboration. And that's why we have partnered with our neurologists and radiologists to sort of have this as a collaborative offer. And that a lot of meetings, a lot of conversations, we're all physicians, and that does work. It just takes a lot of persistence, time, and coming to it from a bridge forming perspective rather than pounding your chest and trying to carve a territory perspective. Nevertheless, it's something that over time does work.
Great. I'm going to jump to you, Dr. Matsko, with a final question as we're winding down the session. What would you say has been the number one obstacle in creating a successful HIFU program? And briefly, if you can.
Yeah, the main obstacle was, of course, lack of reimbursement at the starting phase. So in Germany, as you have a social security system and even a security system that pays all health healthcare costs, has a problem to convince the patient to pay out of the pocket for this treatment option. And we survived 1.5 years with this, and then we started to have difficulties. So I was very lucky to convince, after 1.5 years, to convince a insurance company to give us reimbursement. So I think this is to bring a business case into life, the main obstacle.
Right. Dr. Sani?
For us, the main obstacle at the very beginning was probably unique to my situation, being a university setting, was bringing everybody to the table from different disciplines and having everyone agree to bring technology forward. And this is after we got past the administrative buy-in by way of showing that this is something that actually can be revenue positive. After that, it's a question of, well, these patients who are being treated otherwise are going to not come this way. And by collaboration, we were able to surpass that. But that took a lot of meetings, a lot of talks, just a lot of open, frank conversations. That was probably our biggest difficulty.
And Dr. Cianti, 30 seconds.
Very quickly, the same issues. Reimbursement obviously has been incredibly important, and certainly we have to deal with the fact that our ultrasound treatments are not within our current clinical guidelines in the United States, and so obviously more data and more published research is going to help with that. But very similar to what everyone else has been dealing with.
Great. Well, thank you very much to the three of you for your comments on this panel. I really appreciate how you've been responsive and sensitive to your colleagues' opportunities to speak. Great conversation, and I want to congratulate each of you on the success that you've had in your fields. You're certainly leaders, and I appreciate the work that you've done for the field and in support of the foundation. Have a great rest of the week, and thank you again.